Sean's ready to go.
The broadcast is now starting. All attendees are in listen-only mode.
So thank you for coming online. We're going to start the webinar. Some people may join us as we go along, but I think we should start. We'll start now. So just to introduce myself, I'm John Muscaderi. I'm the scientific director for TVN. And for those of you who may not be familiar with TVN, TVN is a national non-for-profit network that's funded by the National Centers of Excellence, and our mission and focus is to improve the care of the frail elderly. Towards this end, we have a variety of initiatives, including research programs, knowledge translation efforts, training of highly qualified personnel. But this webinar series is part of our knowledge translation efforts, and the goal of this webinar series is to increase the awareness and challenges of the needs faced by this patient population. So just to highlight some of our upcoming webinars that we have there on this screen. The webinars are going to occur on the first Wednesday of every month. Our next webinar is December 3rd at 12 noon, and that will be, the topic for that one will be moving evidence into practice and policy, and Jana Holroyd-Leduc from University of Alberta will be presenting on that one. Other webinars then in the new year, January 7th, February 4th, March 4th, April 1st, and May 6th. The topics and speakers are in the process of being finalized, and these will be communicated shortly. And you can follow us on Twitter for registration details. Now these webinars will also be recorded and be available on our website if you want to go back and look at them. As we plan the webinar series going forward, if anybody on the line, or if you can think of any good speakers, or if you have any suggestions as to topics for future webinars, or you wish to present your area of interest or area of research, please let us know. We anticipate that these webinars will continue on into the indefinite future, and today we have over 200 participants registered, and we'd like to gradually increase the audience to make this really informative and meet the needs of our community. So that's a bit about the background of why we're here today, and again, thank you for taking time out of your busy schedules to attend. So today's webinar is which is a topic which is central to our goals, and that's frailty in the elderly. And we're fortunate to have Melissa Andrew to present on that, and I will introduce Melissa in just a bit of time. But first of all, some housekeeping issues. So to minimize the noise during the webinar, all microphones will be muted. If you have questions and answers, please submit your questions online during the webinar, and that way, and if you submit them as the webinar goes along, we will collate the questions, and we will get to as many of them as possible at the end of the webinar. So saying that, I'd like to introduce Melissa Andrew, who is an associate professor from Dalhousie University and is a consultant in geriatric medicine at the QE2 Health Sciences Centers. She has a Master's of Public Health at London School of Hygiene and a PhD in interdisciplinary studies at Dalhousie University. She is a principal investigator on a team studying frailty and multi-morbidity as in relation to dementia, so she is well qualified to speak on this topic today, and is also a principal investigator on a serious outcome surveillance network, and is engaged in a variety of other research in this topic. So without further ado, I'm going to turn over the presentation to Melissa. So welcome, and look forward to the presentation.
Great, thank you. And I'm just, can someone clean up? So thank you, everybody, for the invitation to speak today. I hope that it's somewhat helpful to you in sort of thinking about different ways to conceptualize frailty and perhaps how you might even measure it in your own settings, and how it might impact how we plan clinical care and health services for older people. So I wanted to talk a bit about what frailty is in the first place, and then differentiate it from chronological age, then talk a bit about how it impacts on health and health outcomes, and also why it's important for our health services, and talk about how social circumstances are especially relevant for older people as well, and then reflect at the end and with some time for discussion about implications of all of this. So we know that the population's aging, and certainly with the baby boomers having started to turn 65 just last year, it's going to be a big issue for us in the coming years. And when we, in the care of older people and in geriatrics and gerontology, we think about what we do, we certainly are not set up to look after all older people. And arguably, as you'll see, not all older people need our services. But really, I would argue, and I think many of us agree, that we really need to concentrate on those who are frail. And in order to do that, we really need to understand what frailty is, and also just differentiate it a bit from what aging is. So the next few slides are just sort of a diversion into the world of physics, I guess, and thoughts around how we can apply some different ideas to this. But I would put to you that what it means to be frail or even old is not about your building blocks being old. So the building blocks of life do not age per se, and there's this radioactive decay curve that randomly describes how these elements will decay. And so it's not that a person who's 80 has all of their tissues and whatnot have been around for that long. It's really, there's a lot of turnover. So we need to think about it a bit differently. So aging implies an accelerated risk of failure over time. And really what that means is that the system, because it's important on the system, is more likely to break down if it's aged than it is if it's new. And this is really different than just an idea of the passage of chronological time, so how many months or years somebody or something has been around. So a that had a constant rate of failure over time would get older in terms of chronological time, but it wouldn't be aging in the same way that we mean here. And if you think about another example of this is that, an old car is more likely to break down. It's not just been around for more months and years, it's because it's more likely to fail with time. So the way that our systems are organized can affect their failure over time. And so the example on the left there is the old-fashioned, string of Christmas tree lights, and these are taken from electrical systems. So that would be arranged in series. Whereas the one on the right has electricity supplied to many rooms in the house simultaneously, and that's arranged in parallel. So the one on the left there, really, there's not a lot of room, see if I can get my highlighter up here, for failure. If one of these is lost, then the whole system won't work. I don't know, my highlighter just messes me up. I'll make it go away. Okay, so in living systems, the organs are arranged in this way. If you lose your liver function, then the system is no longer going to work. However, on a tissue level, we have a lot of redundancy. So there are many more nephrons in our kidneys than we need to have kidney function, and it's really only once you've lost a critical mass of nephrons before the kidney function will go off in a relevant way. So there is a lot of redundancy that's built into living systems, and that is really how they prevent failure. Now, an interesting consequence of this is that we should be able to, if we can count up the problems and deficits that have reduced the system's redundancy, we should be able to arrive at some measure of how close to failure that system is. Now, this is different than how machines work. So machines usually rely on just quality control of individual parts, but if you have a toaster and the little part has broken, then the whole toaster is really no longer going to work. In high-stakes systems like jetliners, there is more redundancy that's built in for that reason. So I'll just give you an example of how this may be relevant on a clinical level, and then we'll talk a bit about what frailty is. So illness presentation can be different, or is different, in frail older people than in younger people. So when I talk with students and health professional trainees, we talk about how, if you look up in a textbook, you know what the signs and symptoms of pneumonia are. And those are things like a cough and a fever and shortness of breath. And then you have findings on your investigations, like a white count and chest x-ray findings, etc. But those of us who see frail older people in clinical settings will know that often they don't present in the same way. They may present with confusion or falls and may or may not even have a cough. But it turns out that they then have pneumonia when you go looking. So that's one key thing to get our heads around, is how in our healthcare systems we are identifying and caring for people who are frail and will present in different ways. And the way that we kind of conceptualize this, and it's based on some lots of great work that my colleague Dr. Kenneth Rockwood has done here at Dow, and we'll see some of his research in the coming slides as well, is that as human beings we've evolved key higher order functions that differentiate us from other animals. And these key higher order functions you can kind of think of in your mind now. I'm sure many of you have ideas, and if we had interaction we could get some of them, but I'll tell you what they are. So we walk upright, we can think and divide our attention, we have opposable thumbs and functional abilities, and we have social graces. And so when these things go off, they lead to the types of presentations that we see in frail older people. So they can lead to falls, delirium, acute confusion, functional decline, and incontinence. So if you think of these as the pinnacle of functions that our system, as a complex system, has achieved, people who are fit and not frail are able to take some hits, take acute illness, get an influenza or whatnot, and still maintain these higher order functions. But people who are very vulnerable and are just on the brink of holding it all together will have problems like this when they get any additional problems. So this leads us to what frailty is all about. So I'm sure you all have ideas about what frailty is, and there's certainly lots of literature out there on it, and I'll just summarize a few here and give some examples. Now, it's not even an exhaustive list of examples, just meant to illustrate some of the different approaches. So the word frailty comes up in the literature. If you read in Dickens, frailty conjures up in certain images. We also have different ways that have been used in the research literature to quantify and describe frailty. So some of these include descriptive definitions, where you can see what sort of category a person falls into based on descriptions, and I'll give an example of that in the frailty scale in a few moments. Then there are rules-based definitions, where you say if you have 3 of these 5 things, then you're frail. We also have an approach called deficit accumulation, which builds on that idea of redundancy, where we count up the number of health and functional problems that somebody has, and the example of that is a frailty index. We could define frailty based on having an atypical presentation in the first place. It's kind of like a stress test in that case. It's a little late. You'd ideally like to identify someone who's frail beforehand. Then we can have a frailty as a balance with this balance between assets and deficits, which is a great one to use in terms of clinical practice. We can define frailty based on function and functional dependence. And then there's also a use of something called frailty defining conditions, particularly in administrative databases, where we're trying to draw out and identify people who are frail without being able to actually meet them and do clinical assessments. So although there is vigorous debate in the literature and in the community of researchers on the topic about what frailty is, I think everyone really agrees that frailty is about vulnerability, no matter how you conceptualize it. So the way I'd like to think about it is a balance between things you have going against you and things you have going for you, or in this case between your insults or deficits and reserve. So Dr. Rockwood published this some years ago, and I do find it useful for having a clinical understanding. Really, it's people are in a balance between things that they have going for them and that they have going against them. So somebody who's in a very robust balance between these two sides is able to tolerate more deficits, you know, like an acute flu or an exacerbation of their COPD or whatever it is, and not have a decompensation. But someone who's in a very precarious balance between those two sides will have difficulty compensating for the loss of an asset, such as a caregiver or friend going away on vacation, or having an additional deficit. And those are the people who tip the balance and run into troubles and often will present to our health care systems. So another way to think about frailty is that it's a purely physical phenomenon, and this is the case with the phenotypic definition of frailty that's often used in research studies, especially from the United States. So this definition was put forward by Fried and colleagues and was originally described back in 2001, has been used a lot since. And they define frailty as being 3 or more of these 5 things. So weakness, weight loss, slow walking speed, inactivity, and exhaustion. And notably, there's lots of things that aren't in that definition, right? So cognition, mental health, anything social, and even they've argued that dependence and having those criteria due to a single disease state like Parkinson's disease wouldn't count as being frail because it's something different like Parkinson's. When people have tried to apply this more broadly, many of them have run into issues around how the cognition and the mental health and function are so closely tied in with this that it really is difficult to separate it out. So some people many researchers continue to make the argument that we need to have frailty being something different than functional dependence, being something different than cognitive function. However, I would argue that from a clinical and health services planning point of view, considering these things all together makes a lot of sense. So here we have the next approach, which is the frailty index, or a count of deficits. So this is just one example of many such deficit accumulation approaches that have been done. This one comes from the Canadian Study of Health and Aging, and what we did here was added up deficits in terms of health and function and symptoms. And it's really quite simple. There's no weighting involved. You get 1 point for each problem that you have. Sometimes there's an intermediate grade where you would get ½ a point if you were partially dependent on an item, for example. And then that is divided by the total number of deficits that you've considered. So if we're in a data set that has, say, 50 health deficits that you've considered, and the person has 10 of those wrong, then their frailty index would be 0.2, as you see there. So this is really quite profound in terms of the mathematical principles behind it. So it's been very interesting to see this work evolve over time. And really, every time we've operationalized this, and it's been done in other data sets and countries as well, the distribution is very much the same. It's called the gamma distribution. Some people have no frailty or no problems, and others are very frail. But it's skewed off to the right here, and you can see that where I put the arrow is that there is a maximum frailty that people can tolerate, and this is preserved across all the different times that it's been operationalized. And that maximum is about 0.6 or 0.67, and it really means that people who have more deficits than that are just not able to tolerate them, and then they've died and are no longer in the populations being studied. So that can have some important implications for our health care systems planning as well. You know, if you're seeing somebody who's very frail, you know, sitting at a 0.5 or 6, and considering them for an elective surgery or an invasive procedure, it's very likely that that procedure or surgery itself will bring, even on a temporary basis, additional deficits which may not be tolerable by the person who's very frail. So it's the kind of thing that needs to be considered. To date, we haven't used this in clinical settings in terms of saying, well, your frailty index is 0.46, so this means you shouldn't have this procedure. But it's more like people who have a similar frailty to you are very vulnerable and will have many more adverse events with this proposed procedure than someone who's quite fit, and so that's something you need to take into consideration. So the frailty index has other preserved characteristics as well, including that it increases with age on average, and that women have higher frailty than men, even though women live longer than men and survive longer at any given grade of frailty than men. So that's certainly an area that we're interested in studying more about, why women are able to tolerate frailty more than men. Okay, so we also see that when this is operationalized across different countries and different data sets, the preserved characteristics are seen here. So that in community dwelling older people, there is this accumulation of about 3% in the deficit list per year, whereas the top line there shows for people who are already sick, so in institutionalized samples, people in long-term care, people in cancer registries, for example, their frailty is already high and they have little room to accumulate more deficits. So in fact, they don't tend to have an increase over time. If they get more deficits, then really they're going to be highly likely to die. We can also create a frailty index based on a comprehensive geriatric assessment, and I'll show you this in a few more minutes. But the point here is really to say that age alone, so a chronological age, is a predictor of mortality, of course, but nowhere near as strong as frailty. So here we have a population of people of different ages starting out, and 5 years later, even the people who were 100, some of them, 20% of them in this case, are still alive. However, if you've stratified them into the levels of frailty, with 0.5 being a very frail subset of the population, these people have not survived beyond 2 years. But an interesting point to note is that they don't all, it doesn't predict death in the near term. It doesn't say these people are all going to die within 3 months or 6 months, which is where some of the decision-making around eligibility for palliative care services is made, for example. It's not as easy as that. It's more to say that these people are near the end of life, but you can't tell exactly how near. Another thing that I'll point out to you is really that the similarity in the shape of the curves for people who are very frail to the radioactive decay curve that we saw earlier. So it's as if these people are on the brink. They're sitting there. They may look quite stable for quite a period of time, but they just have one additional deficit that then puts them over the edge of tolerability. So we can use this idea to inform ideas around personal biological age versus the chronological age. So here we have the chronological age on the x-axis, and the y-axis is the frailty index, with more deficits being worse, as you'll recall from the frailty index. So here's the population curve that we would expect on average. Of course, many people don't adhere to the averages. So for example, we have 2 people here. Person A is more frail than average for their age, and person B is less frail. So person, but they're both the same age, they're both 79. So person A has the average frailty of someone who's about 94 years old, so that's akin to their personal biological age. Whereas person B has the frailty of someone who's 64, so that's their personal biological age. And you'll recall from the slide I just showed that the biological age or the frailty is much more predictive of outcomes than the chronological age. So there are different thoughts about what causes frailty. So people have been looking into nutrition. Certainly there's a lot of work on exercise and exercise tolerance. Two topics that I'll just mention briefly that are quite interesting are inflammation and immune senescence as well. So inflammaging is a whole area of research, and one person who's very much out ahead of this is Jan McElhaney, currently in Sudbury. And so she's described inflammaging as an inflammatory state, and it's low grade and it's asymptomatic, but it's systemic, and there are certain profiles of inflammatory markers that would go along with this. So perhaps it's the case that people who have more or less of certain inflammatory markers are more prone to accumulating more health deficits and getting frail. The immune system, of course, also changes with age, and particularly with frailty. So these ones that I've listed here are quite well known, with changes in both cell-mediated immunity and humoral immunity. And perhaps it's the case that people who are more frail have bigger changes than the fitter people in these things. And this is some of the areas for further research that are being undertaken. So a big question for us is, can frailty be prevented, or how should we deal with frailty? So far the best candidates seem to be exercise and social integration, and you know, it would be great if we had the fountain of youth, and if you look online, people will, and companies will tell you that they've found it, and they'll charge an awful lot for it too. But unfortunately, there really isn't anything that we can do in terms of supplements or treatments at this time to reverse frailty. There's good evidence, though, that exercise is helpful to reduce levels of frailty, and increasing evidence around social integration, too. When we're planning our health services, the least we can do is prevent some of the consequences and complications of frailty, and that's really an area that I think has a lot of promise for a group like you folks. So for clinical care, if we think of someone who's frail having a lot of different problems, it's not that they have a single system problem, it's really that they have a lot of things wrong all the way at once. So having a holistic approach would be very important. Focusing on the key higher order functions like function, mobility, and cognition would be important. And we should also be alert to iatrogenic risks, or things that we do to people that are actually harmful. So this leads us to the question of whether hospital care could be provided differently. And so we have, as one of the great things that define Canada, we have our public health care system. And if you look back in the history of that, it was really designed to deal with the biggest threats to health at the time, namely acute illness and catastrophic illness. And it's evolved with the demographic changes now, so that the biggest users of our system are in fact people with chronic illness and many different illnesses, rather than necessarily the single one thing that's wrong. And so in this way, we can see frail older people as really being the canaries in the coal mine who can tell us a lot about the quality of our health systems. So it happens that in the course of health care, particularly in acute care, we do a lot of things to people that are hard to tolerate. So we keep them up at night, we do a lot of tests at any hour of the day, we take away their glasses and their dentures, we tie them up with sometimes restraints even, but also tubes and wires. There's a lot of noise in the environment. You can think on and on about the types of things that we do to people that are really difficult and don't promote health and healing. So fit younger people can tend to come through that relatively well. But a frail older person is going to show us when that system is breaking down. So given that frailty means having many things wrong at once, how should we best treat people who are frail? We can continue to rely on the one thing wrong approach at once, and that's kind of where we are now with subspecialized care, and each area is doing its own thing. But really, if we want to get on top of the frailty issue, I would argue that we need integrated services that focus more on the big picture. So I put this up just as a bit of a local reference to the situation in Halifax, but I think it applies in many other places too. So the one thing wrong at a time approach is really built into our healthcare facilities and systems. So this is just an example of how in Halifax we have all these different buildings, they're even at different sites, and the different services are allocated between the sites. And so getting integrated care is a bit more challenging than it might be if we were thinking more across the system. So one of the questions we wanted to address today was how frailty can be measured in clinical settings. And so there are various tools and assessment strategies that you can use, and really you'd want to consider what your goals are. Do you want to identify people who are frail, perhaps for additional treatment or investigations or discussion, care planning? Do you want to use your assessment to also plan interventions to identify areas which could use treatments or management? And so the goal of what you're doing will inform the decision of how to measure frailty in your setting. So some examples I'll talk about here would be comprehensive geriatric assessment, a frailty scale measure, and also then the idea of a state variable that captures complexity. So comprehensive geriatric assessment is likely a concept that's familiar to many of you, so we won't have to dwell on it too much. But essentially the things we need to capture in that assessment would be cognition, both acute and chronic, mood, communication with hearing, speech, and vision, mobility and balance. Importantly, we think about falls, we think about bowel and bladder continence, weight and nutrition and appetite, and then function in basic and instrumental activities of daily living. And a really key thing to consider here is to understand the difference between a person's presentation now, say when they've come to the emergency department or acute care, versus how they were at baseline, say 2 weeks ago. And so a tool that allows you to tease that out is helpful, because it can show you how acutely ill versus how chronically unwell and frail they are. We also need to consider people's social circumstances and supports, as well as their medical conditions and their medications. And very importantly, when we're doing a medication review, we need to think about whether the medications are appropriate or inappropriate, and do any changes need to be made. And also, are there conditions that are treated too aggressively or not treated enough? So doing a comprehensive geriatric assessment is definitely a good strategy to improve clinical care for older people, and then identify areas that can be focused on for further intervention. You can also use a comprehensive geriatric assessment to create a frailty index by adding up all the different health and functional problems and then dividing by the total number that you have. And when we've done this, this is just one example where we see that people who are mildly frail, according to a frailty index, will have longer survival than people who are severely frail. So currently we're not doing calculations of frailty indices from comprehensive assessments on a routine basis, as I mentioned, but it's certainly something that's being done in research settings. So a second example of a frailty tool is more of a categorization with a frailty scale. So that's a descriptive definition of frailty. This one was published in 2005, and it's been worked on since. And it's also, it derives initially from the Canadian Study of Health and Aging. So here we have, it's actually a 9-point scale over the next two graphs, or next two slides, that show you different categories that people would fall into. So for example, someone who's not dependent for their daily function, but has symptoms that limit their activities and are slowed up. Or fatigue, for example, could be a level 4, which is vulnerable, but not yet frail. So someone who has slowing in their mobility and also needs help with their instrumental activities of daily living would be categorized as mildly frail. Then we have people who are severely frail when they're completely dependent for all of their activities of daily living. Then there are categories as well for people who are near end of life or terminally ill. So when we categorize people on this basis, we do see that the scale predicts outcomes quite strongly, both institutionalization in this case, for example, and survival. So that's a relatively easy scale to implement because it's not based on a lengthy interview process. It's more based on the overall impression that a clinician or even potentially a family member. We've done some work validating this with care partners. So it's more of an overall picture of the person. So an example of what we mean by state variable is really to say we need something that integrates information from all the different systems that the person may have problems with. And ideally, we'd like it to be a simple and easy to understand measure and also something that can be tracked over time so we could see if these people are getting better or worse. So one really great candidate for that would be balance and mobility. And so this is a tool called the Hierarchical Assessment of Balance and Mobility, developed here at Dal by Dr. Rockwood and also Chris McKnight. And what they did was divided balance and mobility into different domains, so mobility, transfers, and balance. And each of these has a hierarchy, so it's much more detailed than just saying, does the person walk or not? Because that really doesn't give you much information about where they are on the scale in between. So, for example, with the mobility one, the worst mobility is needing positioning in bed, and then you can see people rolling over and then sitting up and then putting their legs over the side of the bed, and then eventually they're able to get up and stand and walk. And so you can track their improvement over time or their change over time. So this example given here just shows two people who came in similarly impaired in their mobility. The circle person stabilized with treatment in hospital, then improved, whereas the triangle person has declined and then died on their 4th day in hospital. So some work that's been done here in Halifax has shown that people who decline in the first 2 or 3 days of a hospital stay actually have about 18 times increased risk of having a poor outcome, which is a very strong effect and something that really suggests that this is a very important clinical sign to watch for. So another thing that I wanted to touch on is how health has lots of intrinsic factors like frailty, for example, that we were well aware of, but there are social and extrinsic factors such as social factors that are important too, and that the social history and people's social circumstances are just so important. So really they hold the key in 2 different ways. One is that they in themselves are risk factors for poor health and health outcomes. But they're also so important for us to understand as clinicians and health planners when we're thinking about how to understand a person's circumstance and get them back home again. So for discharge planning, it's just critical to understand where people are in their social circumstances. So we know that numerous social factors are individually associated with health. We know about the socioeconomic gradient in health, for example. We know about social supports and how important they are, how important it is to be engaged in one's community, and also on a bigger level, how the neighborhoods and societies that we live in affect our health. So my aim in talking to you about this is to say that we can conceptually unify this to go from the individual out through these very the concentric circles, really, of different influences. And if we consider the influences at each of those levels, we may be able to better understand people's social vulnerability overall and also how to help. There's lots of evidence linking social factors to older adults' health, and I won't summarize it all in detail, but just give an example. So for mobility and falls, these are outcomes that are very important to seniors. And in fact, we often hear that seniors are more fearful of having cognitive decline, dementia, and also debility and being a burden on their families, they fear that more than they fear death itself. So these are very important outcomes for us to be considering, more than just the usual sort of survival that are done in a lot of epidemiological studies. So with the example of falls, we know that there is a socioeconomic gradient in falls, just as there is with health as a whole. We know that living alone is a risk factor for falls. Not being engaged in one's community is an independent risk factor for falls. And also, though, studies, particularly in the United Kingdom, have shown that living in a poorer neighborhood, which they call an index of deprivation, is actually, in and of itself, a risk factor for falls, even once you consider the person's individual socioeconomic status. So it's the bigger picture of the societies and the context that we live in that is important for older adults' health as well. There are lots of suggestions of how social circumstances affect older people's health, and I've just summarized some of the mechanisms here. So there are health behaviors, of course, smoking, drinking, exercise, and diet. But it's not the whole story. When you adjust for these things, there's still a lot of difference that social factors will make. There are biological and physiological mechanisms at play. Likewise, there are psychological ones and material ones. But even when we consider all of these, this picture is a little bit misleading in that it suggests that this is the whole picture, but in fact it's not. So there are other things that that are still improperly understood about how the social factors will affect older people's health. So I'll just share with you some work that we've done about a social vulnerability index, which is like the frailty index. So it's an accumulation of deficits or problems across different areas of somebody's social life, which when you add them together and create an index just like we did with the frailty index, they impact on people's health. So there are some mathematical similarities, which I won't burden you with. We also see that it increases with age, and that there's an important survival gradient, so that people who are most socially vulnerable will have worse mortality or less survival than people who are socially less vulnerable. An example that I'll share with you of this is we did some work looking at Canadian seniors 70 and over, and we identified the ones who were what we call in the zero state of frailty, so they had nothing wrong with them at baseline. And then we stratified them according to their level of social vulnerability with that whole list of things, from their living situation to their social supports to engaging in communities and how they felt about their neighborhoods. And what we found was that the people who were the most socially vulnerable had over twice the risk of dying over the next 5 years. And so, and this was adjusted for age and sex, and also for alcohol and smoking and exercise. And so we see a lot of studies in the literature that say, a hazard ratio of 2.3, and how exciting is that? It really is all about the absolute differences. Because if you have a big enough sample size in a statin study, for example, you'll show a hazard ratio that's statistically significant. So we wanted to look at the absolute difference in mortality. In fact, it was quite striking. So the people who are the most socially vulnerable here in Canada with our public health care system and social safety net had 20% more mortality at follow-up than the people who were the least socially vulnerable. And these are all people who had nothing wrong with them at baseline in terms of medical and functional problems. So there's more work to be done on that for sure, but it just goes to show that social circumstances are very important and also really intimately related with frailty. So just a few thoughts about implications. So both frailty and social vulnerability have important implications for health of older people, and they also have implications for clinical care. So we can do assessments and measure people's frailty and try to identify that, and we want to think about ways in which that would be helpful, and I'm sure you'll have some you may want to discuss later. So comprehensive geriatric assessment or using a frailty scale, for example, are ways that we could do that. We can also integrate measurement of state variables like mobility and balance into our patterns of clinical care. But in a bigger picture, as we're planning for our health system to move forward, we need to really understand that the users of healthcare are largely going to be seniors with a lot of things wrong. And if we try to clear out the hospitals and wait for the young people with one thing wrong to come and fill the beds, then we're just going to be disappointed. So really, we need to understand that the real patients who we're going to see and we need to plan for are the frail older people who have many things wrong. And so this will have implications for how we coordinate our services, and I'm sure many of you will have ideas about how you can see that going. So there are also important future directions for research. So I would argue that there are lots of applications where frailty can be put to good use in non-traditional settings. For example, I'm doing some work with influenza vaccination and vaccine effectiveness and response to acute illnesses, where you might not have thought that frailty would play a big role, because we often think of influenza as an acute illness. But really, what we're finding is that frailty has a lot to do with how people make decisions about getting the vaccine itself, how they respond to illness, their burden of disease, and also the outcomes. So integrating frailty into different research settings is important. And there are also lots of things, as I kind of mentioned as we went along, about how we need to better understand gender differences in frailty, and also some of the underpinnings from basic science, biological perspective. So I think that's about it, and I'm hoping that we can have a bit of discussion now.
Okay, Melissa, there is a question here. It's a kind of a three-part. How is nutrition evaluated in CGA? What tool is used, and what professional does it?
Okay, that is a very good question. So in the CGA, the comprehensive assessment that I showed you, nutrition is evaluated not using a specific tool, but more saying how is the person's appetite, how has that changed from baseline to now with this acute illness, and is their weight stable or increasing or decreasing. So it's more, because it's integrated into a clinical assessment, it's not like some of the research work that we would do on nutrition where we would have a multi-point item about nutrition screening. And the professional that would do it is whoever's doing the overall assessment. So you can imagine different options for that. So often it's a physician who's doing it. Perhaps when we see people in the emergency department, we would use that. We could have nurses, nurse practitioners contribute. Sometimes teams like to divide up the different areas of a comprehensive assessment and each contribute their own special piece. So have a physiotherapy specialist putting in the mobility and falls part, and then a dietitian putting in the nutrition. I think what you'd have to make a decision on in your own setting what works best. One thing that I might argue is that a lot of a comprehensive geriatric assessment wouldn't require specialists from the different disciplines to necessarily do it. You can gather a lot of the information as a generalist, so an assessor who could come from different backgrounds, and even implement much of the management plan as a generalist. But you may then have some people for whom a consultation with a dietitian is important, or some people for whom specialty physio is required. But having an idea of like a generalist assessor is one way forward that can streamline things.
Okay. Another question that came up was, when using the Rockwood Clinical Frailty Scale in an acute setting, should you score on that day or how the person was just prior to the acute admission?
Yeah, that's such a good question. So I think in an ideal setting, you might even do both to show the change, because understanding baseline is so key to our enterprise. So I'll give you the example of the influenza study that I am involved in. We've been doing both. So we've got a clinical frailty scale, like the 1 through 9, that's supposed to reflect what they were like before they got sick, and then the worst in hospital, and then we do a follow-up with them as well. And likewise, we do a frailty index using all the different items of a geriatric assessment at the 3 time points. So you can see the dynamic change. I mean, if we want to best understand what somebody's actual frailty baseline is, then doing the baseline is the best, and then you can see how they compare to that now. But if you have the opportunity to do both, then you could see, you know, really how much of a hit this acute illness has given them.
Okay. I think this is a little bit further to that. In clinical practice, when would you want to perform a clinical frailty scale? On an admission for a baseline? And when would you want to repeat the scale?
That's a good question. So the practice that I would have is doing it in clinic. Like if I'm seeing people in an outpatient clinic, I would generally do it then. And also, I tend to do it when I see people in the emergency department setting, so that's on admission. So especially because we're interested in capturing what the baseline is, I think those are useful times to do it. We've also got projects underway, and Paige Morehouse, for example, who's involved in TVN, is doing some great work looking at the use of frailty assessments in pre-admission surgery clinics, like people who are planning elective surgeries. And so that would be another time that you could use it. It becomes, well, you know, looking at the change over time is important. I wouldn't say that if you're going to do it once, I don't think that doing it while someone's acutely ill about their current state and only having that is as useful as what their baseline was.
Okay. This might be the last question. Is there a difference between acute frailty and chronic frailty? For example, frailty may arise after an acute illness, and would this be different from frailty that arose over the course of time for multiple comorbidities?
I think that's a great question, and I think we don't know. And whoever asked the question should do a research project on it. Persistent, you know, frailty that's come on newly after, say, discharge from hospital, but persists, you know, out a year or two or whatever, however long you're thinking about the time horizon, is going to be very meaningful. We don't really understand if someone has an acute blip of frailty that goes up, say, during an ICU stay, but then they get back essentially to their baseline. We don't understand, I don't think we understand the long-term implications of that, having had the blip. So that's another area that we need more research on.
Okay. And I just want to let everyone know that this slide presentation and this webinar will be going up on our TVN website either later today or tomorrow morning. Many questions have come in about that. John, did you have anything else to add?
No. Thank you so much, Melissa. That was great, and I think it frames where TVN is very nicely, and certainly highlights that there's certainly a huge amount of more work that needs to be done in this, and including prognostication, including how we improve the care that we provide for this very vulnerable population. So thank you, Melissa, for coming on, and thanks to everybody for coming on this webinar. And please forward to us any suggestions for future topics. This would be in the latter part of 2015, or if you're interested in presenting a webinar, we'd also like to work with anybody that has an interest. So in closing, thank you, Melissa. That was great. Thank you for taking the time out of your busy day, and thanks to everybody for coming on to this webinar.
Thank you. It's been great to join in.
Great.
Thanks.